who are these residents?
With us?
Yes.
Yeah, we are all the Japanese hospital prison, just all, but our residents also. With us?
Yes.
Yeah, sure.
Yeah.
But we are all the Japanese hospital prison, just all. And you are also in Ibero-American surgery, pediatric surgery, and SEUP, uh, many places. Okay, we have around normally between 40 to 100 people uh, looking our webinars. Okay, let me introduce you. Give me an, oh, okay. I will pass again the command to you. Okay, you are already on command.
Okay.
Okay, good morning. I will give you my presentation in Spanish. Oh, buenos días a todos. Muchas gracias por su presencia. Estamos muy contentos de tenerlo a la doctora Lisa Aguiar. Ella es de Portugal, pero nacida en Estados Unidos y profesora asociada de cirugía y urología pediátrica en la Universidad de Brown. El doctor Bradley Dinardo, también asociado al servicio de pediatría y especialista en tumores sólidos en la parte oncológica. Quiero darles la bienvenida y también a mi querido amigo, el doctor Anthony Caldamone, que siempre tiene la gentileza de estar con nosotros para hacer los comentarios debidos. Please, Liza and Brad, you can begin. Thank you very much for your presence.
Thank you for the invitation to present to you. You know, I believe we presented to your group a similar talk on Wilms tumor 5 years ago. And if I remember correctly, it was actually during the COVID pandemic. So a lot has changed for the better since that time. And actually a lot has changed from the perspective of how we manage Wilms tumor. So we're excited to share with you some of those advances today. We have no financial disclosures. And let me just share really briefly the overview of what our talk will be today. Both Liza and I will share a few just general introduction slides on Wilms tumor, providing some background. And then Liza will handle the first portion of the talk with regards to surgical advances, reviewing preoperative evaluation, surgical considerations, including indications and contraindications for surgery, and then give us an update on nephron-sparing approaches for Wilms tumor and minimally invasive surgeries for Wilms resection. I'll take over the second half of the talk to provide an update on the advances we're making in Wilms tumor management overall. And we're happy to take any questions during the talk, and I hope there'll be some time at the end as well. So I'll start with just very basic introduction slide on the epidemiology of pediatric renal tumors. Renal tumors make up the second most common pediatric solid tumor. It represents 6% of the pediatric cancers we see. There are about 14,000 cases per year worldwide. And in the United States, we see about 600 cases per year in terms of renal tumors under the age of 19. About 90% of pediatric renal tumors are Wilms. A very small percentage of pediatric renal tumors are rare histologies, which won't be the focus of our talk, but we will very rarely take care of clear cell sarcoma of the kidney, congenital mesoloblastic nephroma, and other rare histologies. The majority of Wilms tumor that we take care of is non-metastatic. It's also unilateral, but small groups in terms of Wilms tumor patients who have metastatic disease and bilateral disease are important components of how we approach Wilms tumor management today. This is a disease of early childhood. 3/4 of Wilms tumor cases occur in patients between the ages of 0 to 5 years. It's extraordinarily rare, but reported to see Wilms tumor in adolescents as well as in adults. Wilms tumor is actually unique amongst our pediatric tumors in having a slightly higher incidence in females rather than males. It's about 10% more common in females than it is in males. And the peak incidence for Wilms tumor varies according to sex as well. Peak incidence for males is about 1 year of age, as you can see on this graph here on the right, whereas females have sort of a static peak incidence between the ages of 1 and 3. And you can see how bilateral disease, which are these dashed lines at the bottom according to age, represent a very small proportion of what we take care of with regards to Wilms tumor. Liz, do you want to talk pathology?
Sure. So with regards to its pathology, it's derived from a primitive metanephric blastoma, and it has this triphasic appearance. And you can see here, there's often, persistent blastomal cells in these dark blue cells, stromal cells, the light pink, and then epithelial cells, the darker pink. Most Wilms tumor have favorable histology, but percentage of Wilms tumor have anaplastic features. So about 7.5% of Wilms tumor patients have anaplasia. And this is important because it's associated with adverse, prognostic outcomes, mainly due to the fact that anaplastic tumors are more chemotherapy resistant. And we worry particularly about diffuse anaplasia, which has a worse prognosis compared to focal anaplasia. About half to 3/4 of these tumors are associated with TP53 mutations. And you can see here that anaplasia is characterized by hyperchromatic and large nuclei. The green arrows are pointing to those nuclei. And then this giant mitotic figure here with the red arrow. About 17% of Wilms tumors are associated with an underlying congenital syndrome or a genetic predisposition. Although the minority, it's important to identify these because they're at increased risk of bilateral disease and recurrent disease. So WT1, located on chromosome 11p13, is involved in GU development and is a tumor suppressor gene. Mutations of this gene are associated with two main syndromes, Dennis-Drash, which has a very high incidence of Wilms at 70%, and then also associated with ambiguous genitalia, which us as urologists will deal with, as well as early renal failure. Wagner syndrome is associated with a 50% Wilms tumor risk, and that disease is also associated with aniridia, ambiguous genitalia, and late renal failure. WT2 gene, located on 11p15.5, is also associated with an increased risk, especially in the setting of Beckwith-Wiedemann syndrome, which carries a smaller risk, a 5% risk of Wilms tumor, but is also associated with hemihypertrophy, organomegaly, and macroglossia. I should note that isolated hemihypertrophy also carries an increased risk without an official diagnosis of Beckwith-Wiedemann syndrome. Familial Wilms tumor, previously known as FWT1 and FWT2, carries a 2% risk, accounts for 2% of Wilms cases. And those patients typically have an earlier onset of Wilms and have an increased risk of bilateral disease. Screening recommendations for patients who are at increased risk due to cancer predisposition syndromes include an ultrasound every 3 months if your risk is equal to or greater than 5%. So it's usually every 3 months until age 5. Later for Beckwith-Wiedemann syndrome or familial Wilms tumor, and to age 7 due to the later onset, and then age 8 for isolated hemihypertrophy. So who do we refer to for genetics referral? Well, the McGill Interactive Pediatric Oncogenetic Guidelines does have a specific guideline for Wilms tumor. And this guideline just provides a more systematic approach and a standardized approach to who gets referred for genetic counseling as well as genetic testing. You can see here that age plays a role, age less than 2, if there's a history of bilateral or multifocal disease, the presence of nephrogenic Rest-on pathology, and any overgrowth features. In addition, family history, mostly any early family history of cancer, as well as multiple primary cancers in relatives, can prompt a genetics workup. Longer term follow-up of using these guidelines has proven to, that it is an effective approach with it identifying close to all 99.5% of confirmed cancer predisposition syndromes in patients. Its sensitivity is high when compared to germline sequencing, so it is a very solid screening tool. I'll go over some preoperative evaluation considerations. I think that most commonly patients present either with abdominal pain, a palpable mass, or gross hematuria, and the initial imaging is often an abdominal ultrasound. And this will prompt cross-sectional imaging, CT or an MRI of the abdomen and pelvis to really look for the extent of disease and important information for surgical considerations, including vascular involvement like renal vein thrombosis or IVC thrombosis, and disease in the contralateral kidney. Chest imaging, of course, is important for metastatic workup, and we're looking for pulmonary mets. In addition to some basic labs, I think it's important to highlight that all of these patients should get a coagulation panel because about 8% of them will have acquired von Willebrand's disease, which is obviously important from a surgical perspective due to its bleeding risk. And then, of course, urine catecholamines when the tumor origin is really unclear and you're trying to differentiate Wilms from neuroblastoma. Whether to use CT or MRI has been a discussion, and this study shows that CT and MRI have equivalent outcomes when you look for capsular penetration, lymph node involvement, venous extension, and signs of tumor rupture. The MRI in this study did pick up more contralateral disease, but that was very rare and difficult to really conclude anything substantial from this particular study. So the conclusion is that whether to use MRI or CT scan should be based on the availability and institutional expertise. And as we know, MRI typically requires anesthesia in the pediatric population, so the availability of our anesthesia colleagues is important. And of course, MRI is much more expensive. There is some potential benefit with regards to consistency throughout surveillance. So although CT, MRI is, equivocal preoperatively, and I think we typically get at this institution CT for ease and efficiency. For surveillance, you should stay consistent for comparison reasons. I have used 3D printing for workup for surgical planning for bilateral Wilms tumor. This is an example of a patient with bilateral Wilms. As you can see, a large right-sided Wilms tumor and a smaller, very endophytic tumor on the left kidney. After nephrectomy on the right, surgical planning on the left, I thought, it would be important to get a better visualization of where that tumor is because it was so intraparenchymal. And I'll show you a video of the 3T printing. This is obviously prior to the right nephrectomy. You can see here, it kind of gave me a little bit of a better idea of exactly where the tumor was. I also did have radiology with ultrasound in the operating room to better define the margins because it was not as exophytic and visible to the naked eye. And fortunately, this patient had good results with negative margins and is doing well from a nephron sparing perspective. Obviously, you need to have availability or the resource of 3D printing. And fortunately, our plastic surgery department has a pretty sophisticated 3D printer. I'll go over just general differences between the COG and PSYOP protocols with regards to specifically to surgical considerations. The most obvious one is timing. So the COG advocates for upfront nephrectomy and lymph node dissection, plus or minus adjuvant chemotherapy or therapy in general. And PSYOP, obviously, there's neoadjuvant chemotherapy and then a subsequent nephrectomy and lymph node dissection. The advantages are, for COG, we have pre-op unaltered histology, improved lymph node sampling, and we can treat very low risk patients with just surgery alone. Adjuvant chemotherapy is then based on specific tumor biology, so we have those pathology results prior. With regards to advantages under PSYOP, there's you can for sure identify tumor response to chemotherapy. And there's less intraoperative spill, which would upstage to stage 3. And there's more opportunity for minimally invasive surgery and nephron sparing surgery, given the reduced size in general of tumors after neoadjuvant chemotherapy. I'll go over some exceptions for COG upfront resection. So bilateral tumors, a solitary horseshoe kidney, any predisposition syndrome, and significant organ involvement that would increase the morbidity of resection significantly, significant pulmonary mets, and then obviously tumor thrombus above the hepatic veins. And for PSYOP, the consideration, a young age is considered due to the higher risk, the higher chance of it being congenital vasoblastic nephroma. And then you would consider a biopsy greater than age 7 due to the increased incidence of an RCC or a renal cell carcinoma in that age group. Our goals are obviously to safely resect the tumor, to accurately stage it. I'll highlight the importance of consistent documentation with our operative findings, and that includes upon entry, the quality of the peritoneal fluid. We want to always inspect the peritoneum for disease and to document the extent, including palpating the renal vein for thrombus, the IVC, and the ureter. I think it's important to palpate the tumor initially to really decide whether it is indeed resectable, although a lot of our decision making with regards to resectability is done prior to surgery based on cross-sectional imaging. I think intra-op decision making is also plays a role. For unresectable tumors, we proceed with biopsy, and then and we already went through those patients that we would deem unresectable right up front. Lymph node sampling is important, and our goal is to get greater than 5 to 7 lymph nodes. And you can see here for right-sided tumors, we're focusing on the right hilar lymph nodes, the pericaval and the aortic cable window. And then for left-sided tumors, the aortic cable window, the periaortic lymph nodes, and the left hilar lymph nodes. Nephron-sparing surgery has been very well studied in the adult population, and you can see here that the nephron-sparing surgery is now more commonly done than a radical nephrectomy for adult tumors. I suspect that this number is even higher today, and that's mainly because we're dealing mostly with T1 disease, small tumors, and there's more incidental findings from imaging done in the adult population. We know, based on adult literature, that nephron-sparing surgery leads to a lower rate of GFR decline, a lower risk of cardiovascular decline, and there are equivalent oncologic outcomes. So that's why it's standard of care currently. However, in pediatrics, only 7% of our patients are getting nephron-sparing surgery. And that's mainly because we're dealing with very large tumors that do not, qualify for nephron-sparing surgery, especially under COG protocols, which, do not include neoadjuvant chemotherapy. AREN 0534 is the first prospective clinical trial under COG whose goal was to get as many patients with bilateral disease to the point of a bilateral partial nephrectomy. So initially, these patients would get 2 cycles of chemotherapy, and then we would reassess with imaging, and then 2 more cycles of chemotherapy if the patient were still not amenable to partial nephrectomy. After 2 additional cycles, or even after 2 initial cycles, the goal would be to do bilateral partials. Obviously, that is not some patients would not qualify for that, but the surgical outcomes published in 2017 showed that about 40% of these patients ended up being amenable to bilateral partial nephrectomies. Half of them had a radical nephrectomy on one side and a partial on the other side, and then less commonly you'd have complete response on one side or a bilateral total nephrectomy. And you can see here that historically the event-free survival at 4 years was 56% and overall survival was 80%, but the results from this trial were significantly better with nephron-sparing surgery. Nephron-sparing surgery in patients with unilateral non-syndromic Wilms tumor is much more controversial. This questionnaire study was published just this year, asking surgeons their comfort level with regards to this clinical setting. And surgeons were most comfortable if patients had received neoadjuvant chemotherapy, pre-op tumor volumes that were pretty low, less than 200 cc's, and if they thought that a greater than 5 millimeter margin was feasible. And as you can expect among the COG surgeons, nephron-sparing surgery for non-syndromic unilateral Wilms tumor was not supported. Minimally invasive surgery has been very well defined for Wilms tumor. Its advantage is, I think, similar to any other minimally invasive surgery, mainly shorter hospital stays, decreased narcotic use, and of course we want equivalent surgical outcomes. This is one of 2 direct comparison studies specifically for Wilms tumor, comparing 15 open versus 17 flap. Notably, there were less lymph nodes sampled in the laparoscopic patient population. longer operative times for laparoscopic surgeries, but event-free survival was similar. And of course, the shorter hospital stay for minimally invasive surgery. From SIOP, this is really the largest series, retrospectively looking at 24 unilateral Wilms tumor between 2001 to 2013. All of them received preoperative chemotherapy, and their tumor volume was relatively low. The results were that, in general, it's comparable to open surgery, but again, lymph node sampling was only adequate in 2 patients. So the ability to harvest enough lymph nodes was compromised. This is a systematic review that was recently published, reviewing minimally invasive surgery for all pediatric renal tumors. And I think it's important to note that for this particular study, looking at reviewing 19 studies, there was really evidence there was insufficient support, I think, for minimally invasive surgery as standard for pediatric renal tumors. I think specifically for Wilms tumor, it has, been reported that, outcomes are equivalent, but because MIS is associated with inadequate lymph node sampling in many cases, and for this particular review, there was more intraoperative tumor spill and positive surgical margins. I think that to declare it as standard of care we're not there just yet. Robotic surgery has been described. I do not use our robot for Wilms tumor cases, but I do think that it's most useful, I would say, for nephron sparing surgery, obviously for a bilateral case or for a small tumor in a patient with predisposition syndrome. Its advantages, I use the robot for other surgeries, but its advantages are clear. There's great visual magnification. There's, you have tremor filtered instruments compared to like traditional stick lap, and there's increased articulation. There's also improved ergonomics for the surgeon, so it's a much more comfortable procedure. I don't have experience, but it has been described, and I think I would consider it for a partial nephrectomy.
Yeah, great. Thanks, Liza. Yeah, I'm excited to share with you the advances in Wilms tumor management that we've been making from an oncology perspective. But let's start just briefly with some historical context. Wilms tumor represents one of our biggest success stories in pediatric cancer, from a disease that 100 years ago was nearly universally fatal when treated with surgical resection alone, to a disease where we are now curing over 90% of patients today using multimodal therapy. Outcomes began to improve for Wilms tumor patients in the 1930s with improved surgical techniques, and importantly, the advent of abdominal radiation in the postoperative setting for these patients, which was pioneered in Boston at Boston Children's Hospital in 1935. But you can see outcomes really start to increase along this graph with the routine use of chemotherapy, with the identification of dactinomycin in 1958 and subsequently vincristine as very active agents for Wilms tumor. We've reached that 90% cure rate on the basis of a number of sequential clinical trials. And really the fundamental principles in terms of how we treat Wilms tumor today were established by a cooperative group known as the National Wilms Tumor Study Group, which subsequently merged into the Children's Oncology Group in the 2000s. But the NWTS group ran 5 sequential clinical trials from 1969 to 2001, and their findings are fundamental in terms of how we approach Wilms management today. That includes the use of vincristine and dactinomycin as our most active chemotherapy combination, which we refer to as the EE4A regimen. They also established the use of doxorubicin in patients with advanced disease when combined with vincristine and dactinomycin, what we call the DD4A regimen, improving outcomes for patients with stage 3 and stage 4 disease. Other findings from the NWTS group that are essential in terms of how we manage patients today include the use of 10 gray of flank or whole abdominal radiation for patients with stage 3 disease, the negative prognostic considerations for either pre or intraoperative tumor spillage, and lastly, but importantly, the role for nephrectomy alone without the need for adjuvant therapy in our lowest risk patients, who are those kids who are under the age of 2 with small stage 1 favorable histology Wilms tumor. So we're at a place where we're curing 90% of patients today, but there still exist these small subgroups of patients whose outcomes remain limited. And that includes patients who have favorable histology Wilms, but have metastatic disease, who historically have had event-free survivals closer to 70 or 75%. It also includes patients with bilateral disease, as Liza discussed, who historically have had a 12% risk of end-stage renal disease. And lastly, it includes our highest risk patients who continue to have really unfavorable outcomes, which includes our stage 4 patients who have diffuse anaplasia and have only a 50% overall survival, and our patients who relapse after undergoing first-line therapy for Wilms tumor, who similarly have outcomes less than 50%. And then it's also important to recognize that amongst those 90% of patients who we are curing, about a quarter of those patients later in life will have severe late toxicity from the therapy that we put them through. And this also represents an area where we have room to improve based on risks for cardiac dysfunction, infertility, radiation effects, and so on in our Wilms tumor survivors. So where do we go from here? The rest of the talk, I'm going to share with you the advances that we've been making over the last 5 to 10 years. And what those advances have really focused on are threefold and listed here. There's been a tremendous amount of work to improve and refine our ability to risk stratify patients. You know, historically, we decide patients' treatment based on their stage and their histology, but we've really moved to a place where we are using tumor biology and biomarkers to make treatment decisions for these patients. The other major breakthrough that we've made in Wilms tumor management is our approach to patients who have pulmonary metastases and using a response-based approach to their therapy, which we will walk through. And then finally, the last trend that we are seeing is an effort to intensify chemotherapy and really push the limits of toxicity for those patients who have really poor survival, the diffuse anaplastic Wilms patients and the patients who are relapsing with Wilms. All three of these trends together are really putting us in a place where we are trying to identify those patients who have the most favorable prognostic factors, have excellent outcomes, and decrease the intensity of their treatment to minimize those late effects in our survivors. While at the same time, we are identifying those highest risk patients and working to intensify their treatment to improve their suboptimal outcomes. So I'm going to start by talking through our modern use of biomarkers to risk stratify patients. Again, using tumor biology to guide treatment. Our ability to use tumor biology in Wilms tumor was proven 20 years ago with the identification of 2 chromosomal abnormalities, which when combined represent a very adverse prognostic factor in patients with Wilms. What we're referring to is loss of heterozygosity at the chromosome 1p loci, as well as loss of heterozygosity or LOH at the chromosome 16q loci. The NWTS team studied this retrospectively and identified patients who had both of these LOH statuses combined as having a negative prognostic factor. And that's demonstrated in these two Kaplan-Meier curves at the bottom. Having this combination of LOH1P and 16q is rare. It only occurs in about 6% of favorable histology Wilms tumor. But outcomes are decreased in all stages of Wilms tumor if this is present. This graph here is showing us patients with stage 1 and 2 favorable histology Wilms tumor, and having combined LOH, which is this yellow line, results in a much worse prognosis compared to those patients who lack the LOH completely. Similarly, amongst patients with stage 3 and 4 disease, having the presence of LOH, 1P, and 16q is negatively prognostic compared to those patients who lack it completely. So our next generation of clinical trials tested a strategy of intensifying treatment for these rare patients when the combined LOH was identified. And this was done in 2 concurrent clinical trials through the Children's Oncology Group. In the first trial, patients with stage 1 or 2 Wilms tumor, who historically would be treated with our 2-drug chemotherapy regimen, if they had this combined LOH status, we intensified their treatment with the addition of doxorubicin. And with that therapy, we dramatically improved outcomes from this dashed red line to patients having outcomes nearing 90% on this clinical trial. Similarly, in a separate clinical trial, we took patients with stage 3 and 4 disease, and amongst the 6% of patients who had the combined LOH status, we intensified their treatment from our standard 3-drug regimen for these patients to a much more intensified 5-drug regimen, but we showed dramatically improved outcomes for these high-risk patients by making this intensification with their therapy. Of course, this intensification comes at a cost that we should always point out. You know, exposing patients to doxorubicin poses a long-term risk for cardiotoxicity. It also introduces a very small risk for the development of a secondary leukemia. More impactful, in our 5-drug regimen, what we call regimen M, the addition of cyclophosphamide and etoposide present a really significant risk for infertility, as well as a more significant risk for secondary cancers by exposure to those 2 chemotherapy medicines. So more recently, we've identified a biomarker that is perhaps more impactful than the LOH status we just reviewed, which is a gain of a chromosome 1q loci, which we see much more commonly in Wilms tumor than the LOH status before. The NWTS status shows us that about 30% of favorable histology Wilms tumor will have a gain of chromosome 1q. And for all stages of disease, event-free survival for these patients who harbor this gain is reduced. This Kaplan-Meier curve shows patients who lack the 1q gain in this dashed blue line up top, and patients who have the 1q gain in this yellow line. This is for all comers. But where this is most impactful is in our patients who have stage 4 disease. So metastatic Wilms tumor patients who have a 1q gain, we now know have an 8-year event-free survival of only 64%, compared to stage 4 patients who lack this having an event-free survival of 91%. What this represents by identifying this is a real opportunity to improve outcomes for our metastatic patients. If we identify gain of 1q, we should consider, and we are doing this in the setting of a clinical trial, increasing chemotherapy intensity for these patients. Whereas patients who lack 1q gain and additionally lack the LOH status we talked about before, those are patients who we could perhaps consider decreasing chemotherapy intensity to minimize their risk of long-term effects while continuing to achieve excellent outcomes for those patients. For the sake of time, I'm gonna not spend too much time on this, but I'm gonna tell you that we are also looking at biomarkers in more discrete, smaller clinical subsets of patients. So for instance, we know that patients who have stage 3 disease consisting of regional lymph node metastases, if they harbor either LOH of 1P or LOH of 16q, those patients similarly suffer a worse prognosis compared to those patients who have lymph node metastases but lack those negative biomarkers. And so again, what this represents is another opportunity for us to use tumor biology to guide therapy by either increasing our chemotherapy intensity for the patients who harbor this finding, while perhaps decreasing chemotherapy intensity for our stage 3 patients who lack these negative prognostic factors. The last advance that I want to discuss in terms of our ability to identify prognostic factors for Wilms tumor has to do with histologic subtypes. So recent data through Children's Oncology Group has looked at our most favorable cohort of Wilms tumor patients, those who have stage 1 favorable histology Wilms, and specifically looked at those whose diagnostic histology, so pre-treatment histology, is greater than 66% epithelial in nature when looking at that triphasic component. So those patients who have what we call epithelial predominant histology at diagnosis and have a complete resection rendering them stage 1 have outstanding outcomes with 4-year event-free survival approaching 100%, whether they have resection only based on our standard of care, which is to not treat with chemotherapy if under the age of 2 and having a small tumor. But similarly, if we have treated them with our standard EE4A chemotherapy, they have excellent outcomes as well. And so what this represents is an opportunity to ask the question, if we take patients who have stage 1 epithelial predominant favorable histology Wilms, who would typically get chemotherapy after treatment, can we take patients regardless of their age and size of their tumor and not treat them at all in the adjuvant setting if they have this favorable histology? And again, this is an outstanding question that we are looking at in the setting of a current clinical trial. The other histologic subtype that I will mention that I think people are more familiar with is blastemal predominant histology, specifically blastemal predominant histology after being treated with chemotherapy. Of course, this is data that has been well described in the PSYOP group, but more recently in our COG experience, where about 20% of our patients require delayed nephrectomies after upfront chemotherapy. We have identified that about 6% of those patients will have a blastemal predominant histology after treatment with chemotherapy. And outcomes for those patients are significantly less than all other patients with different types of post-treatment histology, with overall survival of only 63% for these patients who have post-chemoblastemal predominant. And again, this is an opportunity for us to improve outcomes for a rare subgroup of patients who unfortunately have poor prognosis going forward. So putting this all together, we have recently in the past 5 to 10 years identified a number of novel prognostic factors that have really allowed us to refine our approach to risk stratification here in Children's Oncology Group in the US in general. This is really well described in a publication in Nature Reviews Urology that was published just 2 months ago and really nicely depicts our current approach to risk stratification and how it has evolved substantially over the past several decades from prior approaches to where we were only using a few basic clinical factors to risk stratify and make treatment decisions. I'm going to switch gears and talk about patients with metastatic disease in the setting of Wilms tumor. About 17% of Wilms tumor patients have metastases at diagnosis. Most commonly, that is isolated pulmonary mets. Approximately 5 to 10% of patients will also have liver metastases at diagnosis. Most commonly, it's concordant with lung mets. Other sites of metastases are exceedingly rare. But regardless, this is a group of patients who historically have had worse survival. This is data from PSYOP in their older clinical trials. Stage 4 disease had event-free survival of approximately 60%. In the NWTS studies, that event-free survival is closer to 75%. I want to highlight for you that, again, going back to biomarkers, if we look at that 1q chromosomal gain that I had mentioned previously, and look at outcomes in stage 4 patients, those that harbor 1Q gain suffer really significantly worse outcomes than those who lack 1Q gain. And 1Q gain is found in higher incidence in patients who have metastatic disease. Approximately 50% of stage 4 Wilms tumor patients will have 1Q gain. So in addition to having a higher relapse risk, these patients are also treated much more intensely and have a much higher incidence of late toxicities as well, as you can imagine. We have made a really major breakthrough in our management of patients with pulmonary metastases in one of our COG clinical trials known as AREN 0533. Based on some preliminary data that had existed from PSYOP, a treatment strategy was developed and tested prospectively in this clinical trial, where we took patients who had stage 4 favorable histology Wilms tumor with isolated pulmonary mets, treated them with, after their nephrectomy, treated them with 2 cycles of our standard 3-drug chemotherapy regimen, and then reassessed response in their lungs with CT. For those patients who had complete resolution of their pulmonary mets and lacked any unfavorable biologic prognostic factors like we described before, we continued them on the standard 3-drug regimen and omitted whole lung radiation, which of course has been our standard. For patients who either had persistent metastases when we reassessed their lungs after 2 cycles of chemo, or had negative biologic prognostic markers, we intensified their treatment to the 5-drug chemotherapy regimen and proceeded with our standard whole lung radiation. The outcomes here are really sort of seminal in terms of pediatric oncology. What we demonstrated is that approximately 42% of patients on this study achieved that rapid response threshold and were able to omit whole lung radiation for them, which really limits late effects for these patients. But in addition, these patients all had outstanding outcomes, whether they were slow responders or rapid responders. 4-year overall survival for these stage 4 patients was 96%, which is really, really outstanding. And you can see in comparison to our previous generation of studies how event-free survival was also statistically improved for these therapies as well. I do want to highlight, though, one key component of this data. So event-free survival for patients who had rapid response, and therefore we omitted their whole lung radiation, was 79% compared to 88% if you gave whole lung radiation for slow response. This wasn't statistically significant, but obviously it's a trend that's important. More recent data looking at this study retrospectively, again, goes back to that chromosomal aberration that we talked about, 1Q gain. Taking the patients who had a rapid response, didn't receive whole lung radiation. If they had 1Q gain, these were the patients who were having bad outcomes. Their 4-year event-free survival was 57%, whereas those patients who lacked this 1Q gain maintained really great event-free survival and a much lower risk of relapse. This is really important information that is dictating how we care for patients today that wasn't available just 5 years ago, and speaks to the importance of using biomarkers to make treatment decisions for these patients. So I would suggest that our standard of care approach to patients with isolated pulmonary mets today in 2025 consists of this algorithm. Upfront nephrectomy with chromosomal analysis of the tumor, looking at the LOH status and 1Q gain, followed by 2 cycles of our 3-drug chemotherapy regimen, and then a follow-up CT chest. For those patients who have complete resolution of their pulmonary nodules and lack those biomarkers, those are the patients who we should treat without pulmonary radiation and continue with our 3-drug chemotherapy strategy. Whereas patients who have either LOH or 1Q gain, although this has not been tested prospectively, or have persistent pulmonary nodules, these are the patients we want to intensify therapy, and these are the patients who we want to administer whole lung radiation for. I want to just sort of take a little side note here and talk about the management of small pulmonary nodules, because this is a frequently asked question when we talk about Wilms tumor, although pediatric solid tumors in general, you know, with the use of high resolution chest CTs that have very thin slice thickness and our ability to pick up pulmonary nodules that are between 1 to 3 millimeters in size, we are of course finding a much higher incidence of these tiny lung nodules. What we know from retrospective data from the NWS clinical trials, for patients who had nodules only seen on CT, so not visible on chest X-ray, and also having a biopsy of those nodules, about 26% of those nodules are benign in nature. Usually they are intraparenchymal or fissural lymph nodes, or they are granulomas. But conversely, if a patient has stage 1 disease otherwise and has these microscopic nodules and you treat them as stage 1, they have a very high relapse rate. The other important consideration to keep in mind is that studies have shown that our pediatric radiologists struggle to be able to distinguish imaging features that would tell us that a sub-centimeter pulmonary nodule is malignant or sub-centimeter pulmonary nodule is benign, with only about a 67% accuracy rate. So how do we approach these challenging situations of sub-centimeter pulmonary nodules? Well, there's no perfect strategy. We know that there are some imaging findings that do favor a sub-centimeter pulmonary nodule being malignant. Specifically in Wilms tumor, we think about concerning findings as being round nodules that have sharp margins and lack calcifications. Nodules that are not located in the fissure are worrisome. Nodules that are peripheral in location and nodules, or seeing a pattern where there are multiple nodules of various sizes, is similarly suspicious for these being true malignant disease. When we're talking about nodules less than 1 centimeter in size, we cannot use nodule size to really distinguish whether they are concerning or not concerning. We should also be aware that there are some atypical characteristics that are described in Wilms tumor pulmonary mets, including patients who have just a solitary nodule that is metastatic. We should also know that nodules can evolve from a solid lesion to a cystic lesion, as depicted here with chemotherapy, and that a tumor embolization, vascular embolization type pattern similarly is rare but described in Wilms tumor as well. This is my personal sort of approach and recommendation to the management of indeterminate sub-centimeter pulmonary nodules on CT chest. When you're seeing these findings at diagnosis, I'm usually very hesitant to recommend a diagnostic biopsy. The only time that I would push our surgeons to go in and biopsy these nodules is if they are truly indeterminate and there are only a few that are easily accessible, and that identifying these metastatic lesions and proving that they are malignant would effectively change our treatment right from the beginning. So that's really referring to patients who have low stage disease who may only get our 2-drug chemotherapy regimen. But in general, I'm very hesitant to push for biopsy at diagnosis. But the inverse is true after we treat with 2 cycles of chemotherapy. If there are indeterminate pulmonary nodules after 2 cycles of chemotherapy, then generally we are trying to encourage more resection of those pulmonary nodules to be able to guide therapy going forward from there. If a biopsy of these nodules after 2 cycles reveals benign findings, then we can avoid pulmonary radiation. If it reveals a fully necrotic tumor and all other factors are favorable, we can avoid pulmonary radiation for those patients as well. But of course, if there is viable tumor there when you resect after 2 cycles of chemo, these are the patients who need pulmonary RT and need intensified chemotherapy. Okay, shifting away from metastatic disease, I just really want to highlight for you how outcomes continue to be dismal for some rare subsets of patients. Our patients who have diffuse anaplastic Wilms tumor, despite highly intensified chemotherapy on our most recent COG clinical trial, continue to have really poor outcomes, particularly those who have stage 4 diffuse anaplastic Wilms, which is highlighted here in purple, event-free survival and overall survival of only 50% despite very toxic chemo. Similarly, our patients who relapse with favorable histology Wilms tumor, if they have previously been treated with our standard 3-drug regimen, they continue to have poor outcomes with survival of only 50%. And again, these represent subgroups where we need to continue our efforts to improve outcomes here for these patients. So let me just sort of wrap up and share with you our sort of approach, our standard of care approach to Wilms tumor management today in 2025. We recommend upfront nephrectomy here in the United States, as Liza reviewed. There are some exceptions to that. In those exceptions, we do recommend an upfront biopsy to be able to obtain histology, and more importantly, to do molecular tumor analysis, which we are now doing routinely on all Wilms tumor patients, with the key molecular findings being the ones that we discussed in the slides earlier. We're also now able to use pretreatment histology, the epithelial predominant cases, which I mentioned, and for patients who have delayed nephrectomy, using blastemal predominant histology to guide treatment decisions. And then ultimately, we're putting multiple different factors together into our risk stratification algorithms to be able to make treatment decisions. And with that approach, we sort of fall into 3 different groups of Wilms tumor patients. There are those who have excellent outcomes. There are those that have good outcomes, but a higher risk for late effects of therapy. And there are those patients who continue to have really unsatisfactory outcomes despite intensified therapy. Here are our treatment regimens corresponding to these different groups, which we won't review for the sake of time. I'm going to leave you with where we sort of move the field forward from here. I mentioned a few times that we have some new ongoing clinical trials where we are testing different approaches to Wilms tumor therapy. That includes 2 COG trials, AREN 1921, and the most recent trial, which is AREN 2231. Some of the major questions that these clinical trials are asking is if, one, can we pursue resection only for older patients who have stage 1 Wilms tumor if they have epithelial predominant histology? Importantly, it is either increasing or decreasing treatment intensity based on the biomarkers that we discussed earlier. It is standardizing an approach for pulmonary metastases, as we described as well, in using those biomarkers to sort of further refine which patients we can avoid pulmonary radiation for. And then lastly, we're really sort of pushing the boundaries of chemotherapy toxicity and intensity for our higher risk patients with the use of a novel 7-drug chemotherapy regimen that we call UH3 to try to improve outcomes for those patients who have survival that is 50% or less. In the publication that I had shared earlier is a really nice breakdown of what these clinical trials are doing and how they are also looking at the inclusion of irinotecan as an active chemotherapy agent with some novel chemotherapy regimens, all done in a way to try to minimize exposure to chemotherapy that causes late toxicity. So I think that wraps us up right on time. Here are conclusions on this final slide. We'll keep them up here for a moment, but we are happy to answer any questions.
Thank you very much, Liza and Brad. And I would like to hear the commentary of Dr. Anthony Caldamone, please.
Well, Liza and Brad, that was an excellent presentation, very, very complimentary. And the only thing I could add to this is that considering the difference in your approach to Wilms tumor based on your talk from 5 years ago, I think it would be inappropriate for us to wait another 5 years for another update on this, because it's certainly a field that's changing so rapidly. But a couple of specific questions, if we have just a minute. Brad, you talked about the 90% survival with Wilms tumor, but also commented on the fact that 25% will have long-term toxicity as a result of at least the intensified treatment protocol that some still require. How long do you follow these from a high risk, at least in the high risk group, as far as long-term toxicity is concerned?
Yeah, Tony, that's a great question. when I first started practicing like almost 15 years ago, we would follow these patients pretty closely during the first 5 years of follow-up, really focused on monitoring for relapse. And then oftentimes these patients would sort of go to their primary care physicians and sort of live out the rest of their lives. But since then, there's been a major effort to really sort of establish survivorship care for patients with pediatric cancers in general, and certainly our Wilms tumor patients make up a big cohort. And so our group, which is sort of standard of care practice in the United States, transitions our patients after about when they've been off therapy for 3 to 5 years, we transition them to a dedicated pediatric cancer survivorship clinic that is a multidisciplinary clinic. It's staffed by a primary care physician in conjunction with a pediatric oncology provider and other subspecialists as well. Endocrinology is oftentimes present. And really what they're focused on is coordinating care specifically from that standpoint of the late toxicities we may expect for these patients. So for Wilms tumor patients, it's thinking about the risk of pulmonary toxicity long-term. It's getting screening echocardiograms for risk of cardiotoxicity. It's trying to coordinate care for patients who are suffering from infertility secondary to therapy. And then also importantly, it's providing close monitoring for that group, that 17% of patients who have an underlying predisposition to Wilms tumor. It is providing sort of closer care and monitoring for the complications that are associated with those genetic conditions as well for those patients.
Yeah, it seems like an excellent model to follow these patients. And then finally, one question for Liza. Liza, you talked about the fact that in the unresectable Wilms, COG is still would recommend upfront biopsy. Back in the days when I was active in this, there was always an argument as to whether that biopsy should be percutaneous or open, with the argument being that the percutaneous biopsy has a risk of sampling error, and you might miss anaplastic disease in a percutaneous sample, or at least more likely to miss anaplastic disease in a percutaneous sampling as opposed to a open sampling. What's the recommendation today?
So we're doing open biopsies to get enough tissue that's adequate for pathologists to provide the information to the oncologists. So now that there are these advances with tumor biology, I think if you're going to upstage the patient to stage 3, then I think it's you get more bang for your buck by doing an open biopsy. So that's currently
is that also true in the PSYOP protocols these days?
My sense is that that PSYOP is continuing their approach of neoadjuvant therapy without tissue diagnosis based on their well-established protocol, which I should say results in really equivalent outcomes for almost all stages of Wilms tumor. But a biopsy is not sort of standardly recommended in PSYOP.
Great. Well, again, brilliant presentation, very complimentary, and we'll see you back in less than 5 years for sure.
More than happy to come back anytime.
Thank you very much, Anthony. Congratulations for your great presentation, amazing presentation, complete presentation, and for the picture also.
That's our son, Carson. He's 6 years old.
Okay, I have a question. Do you recommend any renal screening in patients with genetic predisposition? I don't know.
Sorry, any renal screening?
Yeah. With people with genetic predisposition.
Yes, we do. We typically have those patients follow with a nephrologist, usually from the time that we're identifying that predisposition. Several of those syndromes, Denny's-Drash, Logger, have risk for evolving renal disease, and in patients who have WT1 abnormalities that don't fit concretely into those syndromes. those patients similarly are thought to have a risk for renal disease, even if they don't truly have Denny-Strash or Wager. And so usually we're monitoring them on a very frequent basis with ultrasound, which of course is looking for relapse too. But we're looking at UAs for proteinuria. We're monitoring them for hypertension. And oftentimes our nephrologists will have patients on ACE inhibitors in those situations as well for sort of a renal protective effect.
I think there's in general a low threshold to refer to nephrology for any patient who's had a nephrectomy, has a solitary kidney that had a nephrectomy later than the typical age where the body can demonstrate compensatory hypertrophy. So for all of my patients who've had a nephrectomy over the age of 2, I usually refer to nephrology because their solitary kidney doesn't necessarily demonstrate that compensatory hypertrophy that puts them into a lower risk for long-term issues. So that's pretty standard. For those patients who are obviously born with a solitary kidney or have, a multicystic dysplastic kidney that involutes and can demonstrate compensatory hypertrophy, I'm less worried about those patients.
Thank you. With this actual orientation with IA, what about IA, and do you think that it will be useful, or for example, in the diagnosis or treatment? Artificial intelligence? Are you using, or maybe you hear something you can talk about it?
I think from a surgical perspective, I think we have some pretty good, job protection, because I have yet to, AI will not, I think, take over our technical skills, but I think from a diagnosis standpoint, AI has been proven to be very good at pattern recognition. So with regards to pathology and radiology, I would say that I wouldn't be surprised if AI enhances diagnosis and also contributes to prognostic information with regards to like pathology and biomarkers.
Yeah, we'll be very curious to see from a radiology perspective if we go back to when we were talking about indeterminate sub-centimeter pulmonary nodules and the limited ability of a radiologist to be able to distinguish benign from malignant. We'll be very curious to see if the study, I'm sure the study will be done using AI technology to review those CT scans and see if that could be any more accurate in terms of making that distinction. I'm not aware of that study, happening right now, but I'd be very eager to see those results if and when it does.
Yes, I agree also.
Yeah.
Any question? ¿Alguna pregunta de parte de los oyentes? Okay, I have another, maybe for Liza. Do you have, or do you do any recommendation to avoid tumor ruptures during surgery?
So I think that it's important to understand the most common area of tumor rupture is that like posterior dissection, especially close to the diaphragm. So I'm extra careful with that dissection. And I think that avoiding metal instruments in, other than retraction and like unnecessary, metal dissection or instrument dissection is useful. I, always palm the tumor. I very rarely, use the tips of my finger. I think that it's particularly challenging when there has been subcapsular bleeding, because that area of weakness is just so friable. And so that, I think recently I had an intraoperative tumor rupture where there was such a large subcapsular bleed that it was like handling a balloon, like a very thinly walled balloon. I've had 2 intraoperative ruptures in my career, it's never a good feeling.
Yes.
But I think that it's inevitable that it happens. The best we can do is to decrease handling of the tumor as much as possible, and to be aware that that sticky, non-visible portion of that posterior, specifically superior dissection, is just particularly sensitive. That is often, I think, to be honest with you, the part of that dissection is done at the end of the case. So I think surgeon fatigue is also important to note, like that just getting the tumor out at the end is not necessarily the healthiest goal. It's really just paying close attention to, being as careful as possible, because for us, obviously, we are most stressed out with the hilar dissection typically. And once the hilar dissection is done and our vascular control is complete, we really do want to continue to pay as close attention to that dissection.
Bueno, tú trabajas aquí, lo que tengo que ver cómo va. De momento, hoy no creo que te vayas.
Señor
Mañana vamos.
Daniel, por favor, apague su micrófono.
I think
Gracias.
we did it for him.
Sorry, I'm sorry. May you continue, please?
Yeah, I was just noting that, that posterior dissection is just often the end of the case. And I think it's important for us to take note of, like, maintaining concentration during a longer case and not just focusing on vascular control and bleeding risk.
Sorry. I'm sorry. Let me look for it.
El niñito el botón grande de 16 años.
Daniel, apague su
De la
micrófono,
parte
por
interna de
favor.
me falta, ya hoy
No, I don't find him. Okay, I'm sorry. Por favor, apaguen sus micrófonos. Están interrumpiendo la charla. Gracias. Okay. I'm sorry for the event, but it happens.
No, not at all.
Not direct.
The nature
Okay.
of the-
Okay, guys, thank you very much again. I will not wait for 5 years. I will I will wait the next year maybe to talk on another topic, excellent topic that you always do. And Tony, thank you very much. Thank
You're
you very much
welcome.
for
Welcome.
your presence always and for your support to our service. Okay. Gracias a todos. Maybe any recommendation, Tony? Do you any word for the people?
No, I would say that was a great presentation. I do think it is something that needs to be updated on a more regular basis. Wonderful, wonderful job. Look forward to hearing it again.
Thanks,
Okay,
guys.
thank you so much.
Brad and Liza, thank you very much again. Okay.
Take
Have
care.
a nice
Thank you.
day.
Have a
Okay.
good rest of the day.
Nice to see you.
Bye, everyone. Good to see
You have
everyone.
you have to
Take care.
bring Tony to Bolivia, please.
Yeah, we'll work on that. Okay,
Thank you very
take care.
much.
Take care. Bye-bye.
Okay. For the people para los que me están escuchando, la próxima visita que tenemos es el doctor Douglas Husman de la Mayo Clinic de Rochester. Estará con nosotros con un tema muy importante que ya se los voy a pasar. Muy amable, muchas gracias a todos por su presencia. Hasta pronto.